So today our verse is God has committed to us the message of reconciliation. We are therefore Christ's ambassadors, as though God were making his appeal through us. We implore you on Christ's behalf, be reconciled to God. 2 Corinthians 5:19 to 20. And today we're going to start off with anaphylaxis. Anaphylaxis is a type of distributive shock that will cause CVP, PCWP, SVR to all go down, and it causes cardiac output to go up. And increased cardiac output leads to increased mixed venous O2 saturation due to rapid blood transit through capillaries and incomplete oxygen uptake by tissues. Okay, so in anaphylaxis, the skin is warm, so it looks flushed because of massive histamine mediated vasodilation that increases blood flow to the skin. Okay, so here we have Melvin arrows. We have uh, somebody that presents with increased cardiac output, decreased systemic vascular resistance, and decreased pulm- uh, pulmonary capillary wedge pressure. Um, and this is anaphylaxis. We just said that in anaphylaxis, you're going to have decreased SVR and decreased PCWP, and also decreased CVP, and you're going to have increased cardiac output and increased mixed venous O2 saturation. Okay, so this is what he says. Diagnosis is anaphylactic shock, a type 1 hypersensitivity. Type 1 hypersensitivity. What I've seen in MBME questions is that they want IgE cross-linking on surface of mast cells and basophils. This causes release of histamine and prostaglandin. This causes the recruitment of eosinophils secondarily. Histamine and prostaglandin are vasodilators. This causes decrease in SVR that causes low BP. Cardiac output is increased because of venous return is high, even though there may be some swelling in patients with anaphylaxis. Yeah, even though there may be some swelling in patients with anaphylaxis, fluid is the most is fluid for the most part has not left the blood vessels. Blood pressure is low because SVR is low, but the blood is still being returned venously to the heart. Thus, combined with high heart rate, contributes to overall high cardiac output. The literature, Google, will frequently mention how cardiac output is decreased in anaphylaxis, but it is wrong on USMLE. Okay, so remember, cardiac output is increased in anaphylaxis. Burn that into your head as I am doing right now. PCWP left is equal to left atrial pressure, which is the pressure in your left atrium. This may be low or normal. I'm gonna go with low, but often the USM will force you to choose an up or down arrow for shock questions. The important point is to know that PCWP will simply just not be high. Right. So remember, PCWP is low. Whether it's low or normal doesn't really matter because it can vary depending on the question. PCWP is only high in cardiogenic shock from an MI or left heart pathologies. Why? Because of back pressure into your left ventricle, and that goes into your left atrium. But that's in like left heart failure. Okay? Important point. If the USMLE question gives you CO, SVR, PCWP variables on the vignette and then wants you to pick the diagnosis, pretty much the first thing I always look at is the PCWP. If it's high, you know right away they want cardiogenic shock. The heart can't pump, therefore all that blood that's supposed to leave the left ventricle goes back into the left ventricle, goes into the left atrium, goes into the lungs, so that PCWP will be high because PCWP is the pressure in the left atrium. If it's not high, Doesn't matter whether it's low or normal. You say, okay, cool, not cardiogenic shock, but you should look at the other variables still in order to do the diagnosis. It is my observation with students over years of tutoring that not understanding PCWP is the most common reason people get shock questions wrong. That's why I'm really reinforcing PCWP in this PDF. Okay, fine. Let's answer this. 34-year-old female with worsening skin infection and fever of 103 and BP of 80 by 40 and a heart rate of 120. What are the arrows, up or down? For cardiac output, SVR, and pulmonary capillary wedge pressure. Okay. Worsening skin infection, fever 103, BP. This looks like septic shock. Okay, so in septic shock, cardiac output should be low. SVR, I think in septic shock they're cold. The skin is very cold. So SVR should be oh my goodness, I don't like these. Okay, SVR. Okay, if someone is hot, like the skin is hot, that means there is not enough blood. I mean, sorry, there's a lot of blood. If the skin is hot, there is a lot of blood there. That means that there's vasodilation. So SVR would be high. Wait. So, actually, yeah, diagnosis is correct, septic shock, but it's actually increased cardiac output, decreased SVR, and decreased PCWP. The reason is because um, in when somebody okay in septic shock, the person does have cold skin, and when someone has cold skin in shock, that means that there is peripheral vasoconstriction and increased SVR normally. But in the very special case of septic shock, the patient has cold skin, but they have decreased SVR. This is because of the main issue in septic shock, which is massive vasodilation. So SVR is going to be low. And a cold skin is due to poor perfusion. And in septic shock, you're actually going to have increased cardiac output and decreased PCWP. So the reason you have increased cardiac output is because the body tries to increase heart rate. So in septic shock, cardiac output is up because heart because the body is trying to increase heart rate by sympathetic activation to compensate for severe vasodilation and low SVR, which is why cardiac output is high, especially in the very early stage. So remember, septic shock, cardiac output is high, PCWP is low because LV is fine, pumping fine, and the SVR is low. Okay, next. Maybe we should do one more shot. Is there another shot first? Yeah. Okay. 22-year-old male and bleeding from gunshot wound and drowsy. What are the arrows? Up or down for cardiac output, SVR, and pulmonary capillary wedge pressure. I'm gonna take like a minute to write this down. You can if you want to. So this would be um, drowsy, like gunshot wound bleeding. This would be hemorrhagic, right? Hemorrhagic shock. Is that the word? Or hypovolemic shock? One of them. You just it's the one you lose a lot of blood. Um, so cardiac output. Let's see. Cardiac. Patient is drowsy. That means it's the late stage. So cardiac output, I think, will be down. SVR, SVR, PCWP. I think it would be up. SVR. I'm going to go and say it. It's. Yeah. I think the patient would have cold skin. Okay, so if someone has cold skin, that means the SVR would be high. Let's see. This is what I said. Cardiac output is down, SVR is up, and PCWP is up. Let's see. Oh no. Cardiac output is down, SVR is up, PCWP is down. It's hypovolemic shock. Let's see why PCWP is wrong. I mean down. So loss of blood volume equals low CO, okay. Decreased stretch of carotid sinus baroreceptors. Okay, so I feel like PCWP is almost never high unless your heart just stops working. Because my thinking was, oh, cardiac output is down, but heart rate is still up in this patient. Heart rate is still up in this patient, so the heart is obviously pumping. But cardiac output is down. There's not enough blood because you're bleeding out. So diagnosis is hypovolemic shock. You have loss of blood volume. You have low cardiac output. You have decreased stretch of carotid sinus baroreceptors. When you have decreased glossopharyngeal firing, decreased vagus firing, and increased sympathetic nerve firing, which will see increased heart rate. SVR is high because epinephrine binding to alpha 1 receptors on the peripheral arterioles. This causes vasoconstriction. This causes higher systemic resistance as compensation for low cardiac output. PCWP is low because blood volume is low. I've seen on an MBMEQ where PCWP is in the normal range for hypovolemic shock. The point is it's not high. Okay, so it's low. Okay, let's do another one. A 9-year-old male has viral infection and low BP, and heart rate is 120. Chest X-ray shows enlarged heart and hazy lung fields and red urine. What are the arrows up or down for cardiac output, SVR, and pulmonary capillary wedge pressure? Okay, so 9-year-old male, viral infection, low BP, high heart rate, chest X-ray shows big heart, and hazy lung fields and red urine. What are the arrows for cardiac output, SVR, and pulmonary wedge pressure? Well, what does he have? Enlarged heart. Okay. Um. Okay. Hazy lung fields. Pulmonary hypertension? Pulmonary edema? Why does it red here? Okay. Viral infection, low BP. Okay, so I'm gonna go with cardiac output. Hmm. Well, if you have hazy lung field, doesn't that mean there's edema backed up into his like lungs? So PCWP would be high, and cardiac output, I guess, would be low. Um, yeah, I think cardiac output is going to be low. PCWP, I think high, and SVR, viral infection. Um, okay, so viral infection. It has viral infection. I guess myocarditis. I don't know. I'm gonna take a wild guess and say that SVR is low. Well, this was cardiogenic shock. SVR is high though. Alright, let's go through this. I always miss one out of three. That's so annoying. I should be so irritated. Ah. Okay, diagnosis is cardiogenic shock, secondary to dilated cardiomyopathy due to Coxsackie B virus. Yeah, I'm being an a-hole by really reinforcing PCWP in relation to shock here. Patient also has IgA nephropathy, red urine, 2 days post viral infection, but this is unrelated to cardiogenic shock. There is an offline MBQ with both of these combined in the presentation. Okay. In cardiogenic shock, heart rate can be low, normal, or high. I've seen questions with it all over the place. Heart rate in and of itself doesn't mean jack crap in terms of pump function. You can have a patient who just had an MI who has a heart rate of 120, but the ejection fraction is through the floor. Um, Cardiac output is low because the heart is not able to pump. So SVR is high in order to compensate for low cardiac output. So SVR, let's see, yeah, it's high. This will help maintain pressure normally. PCWP is high because the left heart can't pump, so the left atrium afterload is increased. Increased PCWP is a hallmark of cardiogenic shock. You have to know that. JVD and increased EVP are also seen in cardiac shock. Decreased heart filling. Okay, right heart filling. Okay, so in cardiogenic shock, that means they have cold skin. Let's check. So in cardiogenic shock, your heart stops working and you're gonna have cold skin, which would mean your SVR is high. Because if SVR is high, that means you have vasoconstriction going on. And vasoconstriction, and you have vasoconstriction, that means your skin is going to be cold because not enough blood is getting to your skin, um, because your body is trying to shunt all the blood that's remaining to the heart, the kidneys, the brain. So your skin is like the last thing your body cares about. So SPO would be high, and the heart in cardiogenic shock, the heart is not pumping, so PCWP is going to be high, and cardiac output is going to be low because remember the heart is failing. Okay, next. 12-year-old boy has a viral infection 1 week ago. 12-year-old male has a viral infection 1 week ago and now has the nosebleeds. What are the arrows? Up, down, or normal? For bleeding time, PT and PTT. Okay, so this patient has ITP. I believe the patient has ITP. So what's going to happen? Bleeding time, A Hep4 is okay. Means bleeding time is okay. Bleeding time is only okay in hemophilia A, heparin, and warfarin. Um, when you give the heparin and warfarin is okay, and vitamin K deficiency. I think bleeding time is okay in those three. We'll check after. But this patient has ITP, that means the bleeding time should be high, and the PT and PTT should be normal. I mean, like, should be fine. Platelets, of course, are going to be decreased. So I believe bleeding time is up. PT and PTT are both normal. Let's check. Yeah, correct. So this patient does have ITP. Bleeding time is up. PT and PTT are both normal. And then the platelets will be down. So there's a chart. Um, Maybe upload it if you guys need it. Just comment down below. You just memorize the chart, and you will never get any of the bleeding disorders, PT, PTT, count. You'll never get it wrong. So if you want it, just comment below, and I will upload the chart. Okay, next. 10-year-old male, and yeah, and there's blood in his knee joint after playing soccer at recess, and his maternal uncle also died early after a mid-head trauma. What are the arrows? Up, down, normal. For bleeding time, PT and PTC. Okay. I did talk about the chart. That doesn't mean I remember all of it. You're supposed to memorize it. Okay, let's go from our memory here. Hemophilia A. I think this could be hemophilia A. So if this is hemophilia A, right? Mm, um, okay, so I'm gonna go and say hemophilia A. You're gonna have normal bleeding time. BT would be normal. PT and PTT. So hemophilia A is factor 8. Factor 8 is what? Is a part of the intrinsic or extrinsic pathway? It is part of the PTT. Yeah, it's part of the PTT pathway. So PTT would be up, PT would be normal. That's what I think. So I said bleeding time is normal, PT is normal, and PTT is up. Let's check it. Yep. Yay! I feel so happy. Okay, so bleeding time is a normal, PT is normal, PTT is up. Ask me how I know this through that chart. Okay, so diagnosis is hemophilia A. Honestly, if you see anyone, any kid, any boy with a bleeding joint issue, The answer is hemophilia A or B, but I like to think of A. Both are X-linked recessive. Hemarthrosis in a school-age boy is textbook vignette for hemophilia. Hemophilia A factor 8 deficiency is more common than B factor 9 deficiency. That's why we went with A. So PTT is elevated because factors 8 and 9 are only in the intrinsic pathway. Exactly. So the reason um, there's a way that Ninja Nerd taught this. Literally, you put X in the middle, and then you put an arrow mark. I'll show you. It's easier if I show you. So look at this. This is the thing that they're oopsies. Well, this is the thing that they're testing. Um, this right here is the intrinsic pathway, and this is the extrinsic pathway. This is the common pathway. So what you have to do is put 10 in the middle. This is clotting factor 10, and think of everything that adds up to 10 or multiplies up to 10. Okay, your entire goal is to get to 10. Let's start with the intrinsic pathway. You have countdown from 12. We have 12. We have 11. We skip 10 because we already have 10 here. Then we have 9. Then we have 8. Okay, so this is these are from 12 to 8. This is a countdown from 12, right? And the only thing that we're missing is 10, which is 10 right here. So the intrinsic pathway has everything from 12 to 10. Okay, I mean 12 to 8, including 10. So that's that. Now, and extrinsic pathway. What you have to multiply your goals to get to 10. So you have to multiply what, I mean, sorry, not multiply. I had to add what and what to get to 10. This is 7. So 7 plus 3 is 10. So factor 7 and factor 3 are part of the extrinsic pathway. So 7 plus 3 is 10. Then we have 12, 11, 9, 8 to get to 10. Okay? Then the common pathway is here. 5 times 2 times 1 is 10. So factors 5, factor 2, and 1 are all part of the common pathway. So this is how we get it. Now, we just talked about hemophilia A. Hemophilia A is part of what pathway? Where is factor 8? This is factor 8. So if this is missing, if this factor 8 is missing, that means that PTT is prolonged. So PT and common pathway are absolutely fine. If factor is busted, only PTT would be elevated. So how do we remember this? For the extrinsic pathway, oh my gosh, for the intrinsic, okay, fine. We can start with the extrinsic. Extrinsic pathway, you only have two. You only have two factors, which are what? 7 and 3. Your goal is to get to 10, right? So 7 and 3 are in the extrinsic pathway. And in the intrinsic pathway, you have 12, 11, 9, 8. All you have everything, including 10. I mean, up to, like that includes up to 10, right? It all leads up to 10. Okay. The common pathway, you have 5, 2, and 1, and 10. So 5 times 2 times 1 is 10. Okay? Now, factor 10 is not a part of the extrinsic or intrinsic pathway. It is a factor of the common pathway. Okay? So I hope that makes it easier. Just look at this like 5 times. You're going to get it. Alright. Now, that's that. Okay, so this is the answer. This is when somebody has a heart attack and then they develop lactic acidosis, in which case you're going to have low pH and you're going to have, okay, so you start off with you're going to have low bicarbonate, which causes low pH. and you're going to have low CO2 to compensate. We'll get into it. And you're going to have decreased cardiac output, increased SVR, and increased PCWP. Okay, the reason is because we'll break it into. There's two. It's like very high yield. There's two parts to this. The first, we're going to address the acid base part. Then we're going to go into the cardiovascular dynamics. So the reason why you have low bicarbonate, low pH, and low CO2 is because when somebody has an MI, that causes lactic acidosis. And in lactic acidosis, there's a lot of H plus in the blood. And to counteract this H plus, the bicarbonate gets eaten up. That's why the bicarbonate here is low. And if there's low bicarbonate, that means the body is acidic, right? Because now the CO2 and bicarbonate is out of whack. So now if there's low bicarbonate, the body is no longer like have alkalosis, have like an alkaline counterpart. So if there's low bicarbonate, that means that there is that means the body is acidic. So if the body is acidic, that causes what? A higher low pH, a low pH, right? And remember, pH always follows the primary issue, which is what here? Which is low bicarbonate. And if you have low bicarbonate, that's a metabolic acidosis, right? Bicarbonate is caused by the kidney, so anything kidney is metabolic. So what causes the low pH? That's caused by low bicarbonate. And pH always follows the primary issue, which is low pH caused by metabolic acidosis. Here. And since the body is too acidic now, the body is going to try to get rid of the CO2. And that's why you have low CO2, because the patient is going to try to blow out all their CO2. So you're going to have hyperventilation and low CO2 in the body. So that's why you have low bicarbonate, low pH, and low CO2 in somebody who has had an MI. So that's that part. So just remember, if someone has MI and they're asking about acid base, like pH, bicarbonate, CO2, just think, when someone has MI, just think they're down. Like, they're down. So just think pH, bicarbonate, CO2 all down. Okay, a lot of people survive a heart attack, but a lot of people don't. So think of it that way. Okay, I know it's like dark, but whatever it takes to memorize, okay? I don't think they're going to ask you why each of these parameters are down, but in case they do, you want to know. That's why I explained it. But for the exam, a lot of times it's just going to be high, up, or down arrows. So if you see MI and you see arrows, that's for CO2, pH, and bicarbonate. Click down for all of them. Now, okay, now for this SVR, cardiac output, and PCWP, you're gonna have to reason through this because it'll trip you up otherwise. When somebody has an MI, that's a cardiogenic shock. That just means your heart stops working. It goes into shock and it stops working. So if your heart stops working, what's going to happen to your cardiac output? It's going to go up or down. It's going to go down. That's why cardiac output is down. If your cardiac output is down, what does that mean? That means your heart is no longer pumping. If your left ventricle is no longer pumping, that means that the blood that's in the left ventricle is going to go into your left atrium. And if there's an increased blood in the left atrium, that means your PCWP is up. That's why PCWP is up here. Now, in cardiogenic shock, the patient's skin is going to be cold and clammy. And that's why the SVR is up. If SVR is up, that means that there's a vasoconstriction in the skin. If there's vasoconstriction in the skin, That means not enough blood is getting into the skin. So blood is hot, right? Blood is what makes like your skin hot. If there's not in increased SVR, if there's not enough blood getting to the skin. If there's not enough blood, that means that there's not enough heat in the skin. That means the patient is going to be cold. That's why you have cardiogenic cold and clammy skin and cardiogenic shock, and that's why you have increased SVR in the cardiogenic shock. Okay, next. This is what we just did. Uh, we're gonna have to go through this. Okay. Mm, I think that so. First, we have a 65-year-old female with history of hypertension, JVD, peripheral edema, and S4 heart zone. What are the arrows? High, low, or normal for left ventricular ejection fraction, left ventricular end diastolic pressure, and left ventricular end diastolic volume? I think the left ventricle ejection fraction would be down. I think LV EDP. Um, I think that pressure will be up, and I think left ventricle end diastolic volume will also be up. But let's check. Okay, so there's no change in LV ejection fraction. The LV end diastolic pressure is up. There's no change in the LV end diastolic volume. Let's see. This is because patient has hypertrophic cardiomyopathy and diastolic dysfunction. S4 stiff left ventricle, pressure overload, diastolic dysfunction. The heart cannot expand properly. Student might immediately say, wait, if the heart can't expand, why is LV volume normal then? Shouldn't volume be low? And diastolic dysfunction, LV can achieve a normal volume, it just merely requires more pressure to get there. Highest yield point is the ejection fraction is not reduced. This is really important. In summary, comparing systolic and diastolic function, S3 is dilated LV, volume overload, systolic dysfunction, dilated cardiomyopathy, S4 is stiff LV, pressure overload. This is diastolic dysfunction, it's restrictive and hypertrophic cardiomyopathies. You have normal LV ejection fraction, increased LV end diastolic pressure, and normal end diastolic volume. Okay, so this patient has end diastolic. Okay, this patient has stiff LV, peripheral edema, JVD. So this patient has right heart failure. Patient has hypertrophic cardiomyopathy and diastolic dysfunction. So the patient has a filling issue. So this is one of those things you just have to memorize because it doesn't make any sense. So in diastolic dysfunction, when somebody has an S4 heart sound, that means there's a increased pressure. That's a increased pressure issue, but not it's not a volume issue. Um, that's why S3 would be a volume issue. S4 is not. S4 is a pressure issue. That's why the pressure here is up. The pressure is the only one that's up. So this is S3 dysfunction. In an S3 dysfunction, you're gonna have that's a systolic dysfunction. You're gonna have a dilated ventricle. The LV ejection fraction is going to be low. LV end diastolic volume will be high. LV end diastolic pressure will be high. Why? S3 happens when a dilated volume overloaded LV fills rapidly. Lots of blood enters an already outstretched ventricle, and so there will be high volume and high pressure, but the ventricle can't pump, so the ejection fraction is low. Okay, so high volume and high pressure, but the ventricle can't pump. The ventricle cannot pump. So, yeah, the ventricle cannot pump. So that's why the ejection fraction is low. It's too big. So the left ventricle, the left ventricle is like too big. Think of like someone's like that's like 600 pounds. They can't move as efficiently as a 150-pound person, right? So think of the LV as a really big. Think of my 600-pound life. That patient cannot move and pump pump, walk, jump efficiently as a 150-pound person. So think of their output as being low. That's why the ejection fraction um, in S3 is low. And you're gonna have high pressure and high LV volume because there's a lot of volume in the left ventricle. S3 just means volume overload. That's what it means. So LV volume and pressure is going to be really up. There's a lot of volume, there's always going to be a lot of pressure. That's why LV diastolic pressure and LV and diastolic volume is up, and the LV ejection fraction is low in S3 dysfunction. We can get back to this, but I'm gonna go through my Uworld journal. We're talking about hereditary spherocytosis. This is an autosomal genetic pattern. Anemia due to RBC cell membrane defect, spectrin ankyrin. So this is anemia due to RBC cytoskeleton abnormalities. Spherocytes will be destroyed by spleen. You see hemolytic anemia, jaundice, splenomegaly, and spherocytes accumulate in the spleen. Paravirus B19 infections increase hemolysis, which leads to jaundice and fatigue. So in hereditary spherocytosis, you see spherocytes. Is a RBC cell membrane defect. The spectrin ankyrin, so this is anemia due to RBC cytoskeleton abnormalities. Spherocytes will be destroyed by the spleen. You see hemolytic anemia, jaundice, splenomegaly, because the spherocytes accumulate in the spleen, and eventually the spherocytes will be destroyed by the spleen. And the reason you have anemia is because one, the RBCs are destroyed by the spleen, and it's like a abnormal shape of the um, RBC. It doesn't function properly. So paravirus B19 infection increase hemolysis, which leads to jaundice and fatigue. Next, chronic lymphocytic leukemia. Here, this is the one you see smudge cells in. You see numerous small, mature lymphocytes. Patients will get anemia, thrombocytopenia, and neutropenia. You have increased mature B cells. And you see CD19, CD20, and CD23 positive. So in CLL is where you see smudge cells, and they are CD23 positive. So CLL, think of like love this is how I think of it. I know it's like kind of cringy, but I mean, hey, whatever works, right? So CLL, I think of love for the L in CLL, and when you love somebody, you want to smush them, like smush them. That's what I like think of. Like I tell, let's see, if he's a really cute baby, like it's like, oh my gosh, I just want to squish you because you're so cute. So because you love that child. So you go to, I think of like literally squishing them, but especially the one with the big cheeks and stuff. So I think that's how I think of like love, and I think of smudge cells for that. Okay, next, schistocytes are fragmented RBCs. You see schistocytes in hemolytic uremic syndrome. Okay. Okay, so now, uh, next question. When cancer cells are rapidly destroyed by chemotherapy, like in tumor lysis syndrome, they release the uric acid into the blood. Uric acid can crystallize in the kidney, especially in the acidic parts of the nephron, uh, like in distal tubules and collecting ducts, which can block urine flow and cause acute kidney failure. To prevent this, doctors give a lot of IV fluids and alkalinize the urine, which raises the urine pH, because high urine flow and higher pH keep uric acid dissolved and prevent crystals from forming. So if you had to say summarize this in one line, it would be tumor lysis syndrome damages kidneys by uric acid crystals and hydration, and urine alkalinization prevents it. So when somebody has cancer and then you give them chemotherapy, they can get tumor lysis syndrome, which releases uric acid into the blood. This uric acid crystallizes in the distal tubules and collecting ducts, and this can stop urine from leaving the collecting ducts and cause acute kidney failure because urine backed up damages the kidneys. To prevent this, doctors give IV fluids and alkalinize the acidic part of the nephron, and this raises urine pH and dissolves the uric acid stuck in the collecting tubules. So, one line takeaway is tumor lysis syndrome damages kidneys by uric acid crystals and hydration, and urine alkalinization prevents this. Next. The question is there's a question asking about somebody's having palpitations and the atrial rate is 300 beats per minute and the ventricular rate is 150 rates per minute. They're asking why there is why the rate of conduction from the atria is not transferred to the ventricle. So basically, why is that 300 rates per minute? Why is that not transferred to the ventricular rate of 150 per minute? And the answer is because there is a calcium current within the AV node. So the AV node acts like a gatekeeper using calcium channels to prevent every atrial impulse from reaching the ventricles. Okay? That's why, the correct answer is calcium current within the AV node. So AV node acts like a gatekeeper. The AV node is where? It, here, I'll show you. So this is where the AV node is, right between the atria and the ventricles. The AV node acts like a gatekeeper using calcium channels to prevent every atrial impulse from reaching the ventricle. So the AV node blocks the conduction by using a calcium current within the AV node. Okay, remember that. That's why, whatever, if the atria is 300 beats per minute. That's why it doesn't automatically go to the ventricles. The AV node protects the ventricles from high impulses, from high beating palpitations. Okay, next. The patient has substernal chest pain, shortness of breath for the last few hours. ECG shows ST elevation and multiple leads. Patient diagnosed with acute MI complicated by acute severe heart failure. He has started dobutamine infusion and prepared for coronary catheterization. Which of the following is most likely to be increased due to the medication used in the patient? So someone's having a heart attack. Um, he's given dopamine infusion. They're asking what happens as a result of giving the dopamine infusion. The answer is there is increased myocardial oxygen consumption. Why? In heart failure or acute MI, you generally want to reduce myocardial oxygen demand. However, dobutamine is a special short-term exception. Why dobutamine is still used is because in severe acute heart failure or cardiogenic shock, the immediate problem is low cardiac output. Dobutamine is a B1 agonist and is given temporarily to increase the contractility, improve forward flow and organ perfusion. Even though dobutamine increases myocardial oxygen consumption, the benefit of restoring perfusion outweighs the risk in the short term. Think of it like this: chronic heart failure, you give the beta blockers to decrease the oxygen demand, and in shock, you give dobutamine to save the patient now. Otherwise, they're gonna die. Like acutely, you give dopamine. Oh my gosh, not dopamine. Dobutamine. They all sound the same. So for all intents and purposes, if I said dopamine in the last 2 minutes, I meant dobutamine. Okay, somebody's having a chest pain. So the patient has the patient has heart failure and is having a heart attack. So you give dobutamine infusion. Why? The answer is to increase the myocardial oxygen consumption. So normally you do not want to give anything that would increase the oxygen demand. You don't want anything that causes the heart to work harder in heart failure because the heart is already failing. But here, dobutamine is only given in very severe and acute cases, because if you don't give the patient dobutamine now, the patient will die. So you have to know dobutamine increases cardiac output, but also increases myocardial oxygen demand, acceptable only short term. Okay, so dobutamine is a beta 1 agonist. It's given temporarily to increase the contractility, improve forward flow, and organ perfusion. Even though dobutamine increases myocardial oxygen consumption, the benefit of restoring perfusion outweighs the risk in the short term. Okay. In chronic heart failure, you give beta blockers to decrease the oxygen demand of the heart. And in cardiogenic shock or decompensated heart failure, you give dobutamine, which is a B1 agonist, to save the patient now. So takeaway is that dobutamine increases myocardial oxygen consumption. Okay. And the question is, as you age, what happens to PaO2, PaCO2, and AA gradient? The answer is PaO2 decreases, PaCO2 is normal, and AA gradient increases. Why? As you age, PaO2 decreases because oxygen in the lungs cannot shift into the blood easily, so PaO2 will decrease. PaCO2 is unchanged because as you age, CO2 is still produced at the same rate, and because CO2 diffuses easily, the lungs can remove and replace CO2 at the same time. So as you get older, CO2 does not change. So that's why PaCO2 is normal, and AA gradient is the difference in the oxygen in the lungs and the blood vessels. So as you age, that is going to increase. AA gradient will increase. So normal aging causes a decrease in PaO2, normal PaCO2, and increase in AA gradient. Okay, next, let's look at Millman review arrows. So, 60-year-old man and recovering in hospital following hip surgery and on morphine for pain. Physical exam shows mild crackles at the lung bases bilaterally. Respiratory rate is 8 per minute. Normal is 12 to 20. What are the arrows? Up, down for CO2 and AA. So this patient has hypoventilation because they're not breathing enough. So that means the CO2 will accumulate, so CO2 will be up, and A gradient is the difference between the lungs and the blood vessels in the body, and that will be normal in this patient coming off of surgery on opioids. Okay, so the reason is because um, in someone on opioids after surgery, PaCO2 increases due to hypoventilation. They're not breathing enough, and while the AA gradient remains normal because oxygen transfer across the alveoli is intact. So remember that. Okay. So AA gradient is increased in somebody um, that is 80 years old, and normal in someone that's coming off of surgery that was on morphine or opioids. All right. 1 second. Okay. So let's try to find. Let's do this one. Never mind. We just did it. Maybe we should go to the top of the list and do this so that you know they can answer questions easily from the top. So he says that this is the document you're supposed to go through. If you just pick one document, he said go through this, because a lot of people that fail the step one is because they don't know how to. They don't know the arrows. Maybe you should do AA gradient before that. AA. Okay. All right. So, 65-year-old male and long-standing history of hypertension and smoking, S3 heart sound, sleeps on 4 pills at night to facilitate breathing. What are the arrows for this patient? A gradient, pulmonary capillary wedge pressure. Okay. Um, S3 heart sound. That means the left ventricle is overloaded. Pulmonary capillary wedge pressure should be up. What are the arrows? Um, A gradient is the difference in the lungs and the blood vessels. So in somebody that has overflow of volume in the left ventricle, they would have pulmonary edema also because the backflow of blood from the left atrium to the lungs, and I imagine the lungs cannot work as efficiently, so the oxygen cannot diffuse properly from the lungs to the blood vessels. I would think A gradient is up because the difference would be higher, right? I'm gonna say A gradient is up and the PCWP is up in both. Let's see. Yeah. Yes. Okay. So here, in somebody who has dilated cardiomyopathy, S3 heart sound, and a dilated left ventricle with a systolic dysfunction, you're going to have an increased PCWP because the fluid backs up from the left ventricle to the left atrium to the lungs, and you're also going to have an increased AA gradient because the lungs have so much fluid in it that the lungs can shift oxygen from the lungs to the blood vessels, so the AA gradient goes up. That's what happens here. Okay, now let's go AA gradient. Okay, so here's another one. 25-year-old male, non-smoker, progressively worsening SOB, and the chest X-ray shows bolus changes. Dad died of alcoholic liver disease at age 45. What are the arrows for residual volume or to PO2A gradient? Okay. I have to write this down. Let's see. Okay. Non-smoker, 25. Worsening SOB, chest X-ray shows bolus changes. Dad died of alcohol liver disease at age 45. What are the arrows? Okay. Um. Okay. I think this guy has what's it called? Alpha one. I guess I don't know. Alpha one antitrypsin deficiency, maybe. Um. Well, yeah. Let's go with it. Let's say they have alpha one antitrypsin deficiency. Residual volume. Residual volume is the amount of air that's left in your lungs after you breathe out. So you can't breathe out. I think residual volume will be up. RV. Okay. RV is up. Arterial PO2. Mm, I think it's decreased. A gradient. I think it's increased. Let's see. Oh yes, the diagnosis is correct. Residual volume is up. Arterial PO2 is down. AA gradient. I feel so happy. I feel so accomplished. I'm not even kidding. I know I got two questions right, but still, I feel very, very happy right now. Okay, I got the diagnosis. Got the arrows. We're going. We're going places. Okay. So, alpha one antitrypsin is a protease um, made in the liver that breaks down elastase in the lungs. So alpha one antitrypsin is something you need, right? Alpha one antitrypsin, it breaks down elastase in the lungs. Elastase is what kills your lungs. So in normal people, we have the perfect amount of antitrypsin to kill off the elastase in the lungs. When somebody with alpha 1 antitrypsin deficiency does not have alpha 1 alpha 1 antitrypsin to kill off the elastase. So what happens? Elastase builds up, and then if elastase builds up in this patient gets destruction of the lungs. So if alpha 1 antitrypsin is present, there's less elastase and less destruction of the lung. This in this deficiency, we get emphysema due to lung destruction. If you see something known, if you see bolus changes on chest X-ray, it means emphysema on the USMLE. Okay, emphysema is an obstructive lung disease, right? Sarcoidosis, they're restrictive, but emphysema, asthma, COPD, these are all um, obstructive lung diseases. And in obstructive lung diseases, you are going to have increased residual volume. Okay. So the question asked, what is residual volume? Residual volume is the amount of air left in your lungs after you forcefully exhale as much as possible. So when somebody who has emphysema, you inhale. Okay, so you inhale, you exhale, yes, but then residual volume is the amount of air that's left in your lungs after you forcefully exhale. And in somebody with COPD, emphysema, or any type of obstructive lung disease, the problem is you can't breathe out. So um, you're gonna have uh, if you can't breathe out, you're gonna have more oxygen or air in your lungs. So that's why residual volume is increased here. Okay. Oops. So I think we did all the AA gradients on Melman high yield arrows. Next question is um, about respiratory distress syndrome. People who drown can get ARDS, which is acute respiratory distress syndrome, by aspirating water. Survivors can get decreased lung function. The phase one would be hyaline membranes developing. Phase two would be endothelial cells, pneumocytes, fibroblasts repair damage. Collagen is deposited in interstitium, which can lead to scarring. Phase three is interstitial fibrosis develops, which is irreversible. But most patients don't progress to this. Most patients progress to phase two and then recover. So most patients have an increased alveolar arterial O2 gradient. Um, increased alveolar arterial O2 gradient is just AA gradient. So somebody who has ARDS that progresses to phase two and then recovers has an increased AA gradient. In phase two, you're going to have interstitial inflammation, proliferation of pneumocytes, endothelial cells, and fibroblasts, and collagen deposition. In the very first phase of ARDS, you're going to have hyaline membranes acute inflammation. The last stage would be phase three of fibrosis and does not occur in all patients. Next, pneumothorax. This is a tall, thin young man with sudden shortness of breath, crepitus, and decreased breath sounds in one lung. That's pneumothorax. Patient will have loss of intrapleural negative pressure, so pressure increases and shifts mediastinum to the opposite side, causing SVC compression and decreased venous return. Pneumothorax is an emergency and seen in cystic fibrosis patients. The risk factors for pneumothorax is age less than 40, tall and thin, male sex, and smoking. You will see a contralateral mediastinal shift. Okay, so next question. Tactile fremitus is decreased in pleural effusion. Tactile fremitus is the vibration you feel on the chest wall when a patient speaks, which increases with lung consolidation like pneumonia and decreases with air or fluid like pneumothorax or pleural effusion. Asbestos-related pleural disease is characterized by pleural plaques like focal pleural thickening, typically with calcifications. Common occupational exposures include shipbuilding, insulation manufacturing, and application, and drywall application. Most affected patients remain asymptomatic for 20 to 30 years following initial exposure. Okay, so asbestos. If somebody has asbestos poisoning or toxicity, you're going to see pleural plaques. So you're going to see plaques around your lungs. And these patients, they have traditionally worked in shipbuilding, insulation manufacturing and application, and drywall application. Next. Pulmonary arterial hypertension affects young women and can be familial. It is familial. It is characterized by luminal narrowing of the pulmonary arteries and arterioles with medial hypertrophy, intimal fibrosis, and the eventual development of plexiform lesions. Bosentan is a competitive antagonist of endothelin receptors used in the treatment of PAH. In hepatic hydrothorax, acidic fluid from the abdomen due to liver disease moves through small defects in the diaphragm into the pleural space, most commonly the right pleural space. So in hepatic hydrothorax, acidic fluid from the abdomen due to liver cirrhosis moves through small defects in the diaphragm into the pleural space, most commonly the right pleural space. Pleural effusions are divided into transudative and exudative based mainly on protein and LDH content in the pleural fluid. So pleural effusions are divided into transudative and exudative based mainly on protein and LDH content in the pleural fluid. So pleural effusions are divided into transudative and exudative based mainly on protein and LDH content in the pleural fluid. Transudative effusions have low protein and occur when fluid moves into the pleural space due to pressure problems, such as increased hydrostatic pressure, heart failure, or decreased oncotic pressure, like cirrhosis and low albumin. Exudative effusions have high protein and occur due to inflammation, which makes blood vessels leaky, allowing protein-rich fluid to enter the pleural space, as seen in infection, cancer, autoimmune disease. Pleural effusions are divided into transudative and exudative based mainly on protein and LDH content in the pleural fluid. Transudative effusions have low protein and occur when fluid moves into the pleural space due to pressure problems such as increased hydrostatic pressure, seen in heart failure, or decreased oncotic pressure, cirrhosis, low albumin. Exudative effusions have high protein and occur due to exudative effusions have high protein and occur due to inflammation, which makes blood vessels leaky, allowing protein-rich fluid to enter the pleural space as seen in infection, cancer, and autoimmune disease. So transudative effusions have low protein and occur when fluid moves into the pleural space due to pressure problems. And you see increased hydrostatic pressure and decreased oncotic pressure. Exudative effusions have high protein and occur in cancer, infection, and autoimmune disease. Acute pancreatitis can trigger ARDS because it releases inflammatory cytokines and enzymes into the bloodstream that damage the lungs, alveolar, and capillary lining. This damage makes the alveoli leaky, causing protein rich pulmonary edema, severe hypoxemia that does not improve with oxygen, and non cardiogenic respiratory failure. Early in ARDS, inflammation and fibrin deposition cause the alveoli to become lined with waxy hyaline membranes, which impair gas exchange. So early in ARDS, inflammation and fibrin deposition cause the alveoli to become lined with waxy hyaline membranes, which impair gas exchange. So the lungs naturally want to collapse inward. The chest wall naturally wants to spring outward. These two opposite forces pull against each other. When the inward pull of the lungs exactly balances the outward pull of the chest wall, you are at a normal resting breathing level. The air left in your lungs after a normal exhale. This lung volume is called functional residual capacity. The air left in your lungs after an exhale is FRC, which is functional residual capacity. At this point, air pressure inside the lungs equals outside air pressure, so no air moves in or out. Other key ideas. Compliance means how easily something stretches. Lungs stretch best around normal resting volume. They stretch poorly when very empty or very full. The negative pressure inside the chest, which is intrapleural pressure, exists because The lungs and chest wall are always pulling in opposite directions. The negative pressure is what keeps the lungs open. If you, just one sentence takeaway here is that lungs want to collapse inward. They want to collapse inward, and the chest wall wants to expand outward. Where these forces balance is functional residual capacity, creating negative intrapleural pressure that keeps the lungs open. Okay, so primary TB comes back in the lower lobe of the lungs. Okay, primary TB comes back in the lower lobe of the lungs. Okay, so the GOM complex means primary TB. Primary TB comes back in the lower lobe of the lungs. So the GOM complex, where would you see that? In the lower lobe, okay, of the lungs. Next, a patient on the ventilator would have higher dead space because the ventilator tubing adds extra space where air sits and doesn't reach the lungs for gas exchange. Tidal volume is the amount of air you breathe in or out during a normal breath, which is around 500 ml. Okay, so that's like the amount of tidal volume is the amount of air you breathe in or out during a normal breath, which is 500 ml. Patients coming off ventilator, the question is asking what would their respiratory rate and the tidal volume be? The answer is they have increased. The patient coming off the ventilator would have increased respiratory rate and decreased tidal volume, right? So when somebody comes off a ventilator, they're gonna be gasping for air. They're gonna have high respiratory rate, right? Because you're in distress, your lungs are in distress, your lungs can't even function properly. So you're going to have a higher respiratory rate. The body's trying to get in as much air as it can because the body is underperforming. And and if the lungs are underperforming, is your tidal volume going to be less or high? It's going to be less. That's why patients coming off the ventilator have increased respiratory rate and decreased tidal volume. And they also have higher dead space. I just added that information in case they ask that. Patients coming off the patients on the ventilator have higher dead space because the ventilator tubing adds extra space where air sits and doesn't reach the lungs for gas exchange. So simple explanation: when you breathe in, the air in your nose, trachea, and bronchi doesn't reach the tiny air sacs. That's called anatomical dead space. So dead space is air that fills the tubes, not the gas exchanging parts. So a patient coming off the ventilator has increased respiratory rate, decreased tidal volume, normal or increased ventilation, and decreased dead space because the ventilator circuit dead space is removed. When they're on the ventilator, they have increased dead space. So next we have IgA protease is produced by Neisseria meningitis and Neisseria gonorrhea. This enzyme cleaves secretory IgA at its hinge region, rendering it ineffective. The secretory IgA exists on mucosal surfaces and in secretion, and acts to bind and inhibit the action of pili and fimbria as well as other cell surface antigens that normally mediate mucosal adherence and penetration. So IgA protease is produced by Neisseria meningitis. And this thing produced by Neisseria meningitis cleaves IgA, making IgA ineffective. So IgA is normally found in our body, and it helps to stop. It helps like to so the bacteria can't get into any kind of wet surface in our body, particularly GI tract, right? So IgA is normally made in our body, and a Neisseria produces IgA protease, which is that thing that breaks the IgA in our body down. Okay, next. So the question is asking, somebody has gait instability and dysarthria. Brother died of a neuro disease at age 21. MRI of the brain and spine shows degeneration of the posterior columns and spinocerebellar tract. The patient's condition most closely mimics what? The answer is vitamin E deficiency. So, let's see. This patient, um, has Friedreich's ataxia. What is Friedreich's ataxia? Teenage onset, which is classic for Friedreich ataxia. Symptoms is gait instability and dysarthria. You get ataxia of both the cerebellar and posterior columns. MRI shows the degeneration of the posterior columns, which is loss of vibration and proprioception, and spinocerebellar tracts, which causes ataxia. Family history is what? Brother affected, and that is autosomal recessive inheritance. Typical cause of death is the hypertrophic cardiomyopathy. So this boy has Friedreich's ataxia, which is an issue with the frataxin gene, and it's a GAA repeat issue. Mitochondrial iron accumulation is seen. So this patient in a Friedreich's ataxia has degeneration of the posterior column and spinocerebellar tract degeneration. What does the posterior column do? That so the dorsal and posterior columns are the same thing. So on MRI, you have degeneration of in Friedreich's ataxia. In an MRI, you have degeneration of posterior columns, aka dorsal column, which is loss of vibration and proprioception, and you also have a loss of spinocerebellar tract, which causes ataxia. Your family history, your brother is affected. The family history, the brothers are affected. This is autosomal recessive inheritance. Typical cause of death is hypertrophic cardiomyopathy. So this kid has Friedreich's ataxia in question, and so they're asking what mimics Friedreich's ataxia. The answer is vitamin E deficiency, because vitamin E deficiency um, also has loss of posterior column and spinocerebellar tract. If you have loss of posterior column, you have loss of what? Dorsal column, and this causes impaired vibration and proprioception, and loss of spinocerebellar tract causes ataxia. So what you have to know is that the spinal thalamic the spinal thalamic tract is for pain and temperature. The dorsal column, aka posterior column, is for vibration, fine touch, and proprioception. Do you remember? Do you know how to remember that? Remember Dory from Finding Nemo? Remember she used to like forget stuff all the time, and she would just flop around like she uses vibration. Her fins were always like vibrating. That's how I remember Dory for dorsal column. And dorsal column causes like it carries vibration, fine touch, and proprioception. Next, spinocerebellar tract. This is the one that goes from the muscle to the brain for coordination. This is spinocerebellar tract carries unconscious proprioception. Corticospinal tract carries voluntary motor movement. So the spinocerebellar tract goes from the muscle to the brain. That carries unconscious proprioceptive information, which is body position and movement, from muscles and joints to the cerebellum to help coordinate smooth, balanced movement. Next. So the takeaway from that was that Friedreich's ataxia resembles vitamin E deficiency. So I don't know where we left off, but the next question is which drug increases natriuresis while causing a decrease in angiotensin II concentration and aldosterone production? The answer is a direct renin inhibitor. Why? Because if you remember the pathway, it starts off with angiotensinogen being produced in the liver, and then angiotensinogen is converted to angiotensin 1 using renin, and angiotensin 1 is converted to angiotensin 2 using angiotensin converting enzyme, and angiotensin 2 increases sodium reabsorption in the nephron, increasing aldosterone and sodium in the body. So if you the question is saying which increases natriuresis. So what increases peeing while reducing angiotensin two. So they're asking uh, which inhibits. I mean, like if you inhibit what if you inhibit what um, will angiotensin 2 be decreased, and what's going to cause you to pee more? The answer is a direct renin inhibitor, because if you inhibit renin, you're going to block the very first stage. So if renin is inhibited, angiotensinogen cannot become angiotensin 1. And if there is no angiotensin 1, then you cannot make angiotensin 2. And then you're going to have a decrease in aldosterone production. With a decrease in aldosterone production, you're going to have a decrease in sodium reabsorption and decrease in water reabsorption. And if you can't reabsorb water, you're going to pee it out. If it can't stay in, it has to go out. So more sodium and water are excreted here. So that will be natriuresis and diuresis. Uh, if you give a renin inhibitor. So bottom line, a direct renin inhibitor decreases aldosterone and increases urination. Because remember, if sodium follows water, yeah. So we have decreased aldosterone, right? So if you have decreased sodium, you're gonna have decreased water following it. So if your body has decreased aldosterone, you're gonna have decreased water in the body, and if your body water can't stay in the body, you're gonna have to pee it out. So a direct renin inhibitor decreases aldosterone, that increases urination, and that will lower blood volume and blood pressure. Okay. So next, um, In a pulmonary, okay, so in a PDA, they're asking, uh, in a PDA, they're asking if the afterload is going to be increased or decreased. The answer is in a PDA, you're going to have decreased afterload, and if you close the PDA, you're going to have increased afterload. Okay, so you just have to memorize it that way. PDA is what? PDA is a connection from the left ventricle. Oh my gosh, no, it's not. PDA is a connection from the aorta to the pulmonary artery. So if it's a connection from the aorta, which is coming out of the left ventricle, and then there's a connection from the aorta to the pulmonary artery. The pulmonary artery is coming out of the right ventricle, and so now what that means is that since the left side of the heart has way higher pressure than the right side of the heart, the aorta blood is going to go into the pulmonary artery. And where is the pulmonary artery going to go? It's going to go to the lungs, to the left atrium, to the left ventricle, and you're going to have more blood in the left ventricle in a PDA. If you have more blood in the left ventricle in a PDA, you're going to have decreased afterload because there's more blood, so the left ventricle does not have to push out as hard. It doesn't have to push out as hard into the aorta. But if you close the PDA, it's going to be exactly reverse. There's going to be less blood, and the left ventricle is going to have to push out harder to get blood into the aorta because there is not enough blood when the PDA is closed as compared to before. So takeaway point is that in a PDA you're going to have decreased afterload, but once you close the PDA you're going to have increased afterload. Next. In a pulmonary embolism, what will the values be? I'll have to work this out. Hold on. Okay, so in a pulmonary embolism, the values are going to be like so. You're going to have an increased pH, you're going to have a decreased O2, you're going to have a decreased CO2, and the bicarb is going to be around normal. The reason is because in pulmonary embolism, the process is acute, so which develops over minutes to a few hours. Hypoxemia causes the patient to hyperventilate, leading to decreased PaCO2 and an increased pH, so this would be acute respiratory alkalosis. Although this rise in pH signals the kidneys to excrete the bicarbonate, renal compensation takes like 24 hours to days. It is not. It doesn't happen quickly. It takes a long time for the kidneys to respond and decide to help. So bicarbonate remains normal initially, and then oxygen levels are decreased due to impaired gas exchange from the pulmonary embolism. So in short, you're going to have decreased O2, decreased CO2, normal bicarbonate, and increased pH. Remember a time when I absolutely used to hate these exchange, like this gas exchange questions. But now they don't seem so bad. But they're still, they can still be a piece of work. Okay, next. Plasminogen is an inactive blood protein that is converted into plasmin, which breaks down fibrin clots during fibrinolysis. So plasminogen is inactive, but that plasminogen is converted to plasmin, which breaks down clots. So what's gonna happen in? And there's another question. Wait, hyperactive. Okay, so baby is severely dehydrated. They're asking what causes this. I mean, no, not what causes it. What will the levels be for hematocrit, for serum albumin concentration, and serum uric acid concentration? The answer is that they are all increased. So in dehydration, loss of plasma water causes hemo concentration, leading to increased hematocrit, increased albumin, and increased serum uric acid. Okay. Okay. So next we have uh, vestibular schwannoma. They're they're saying a patient presents with unilateral hearing loss, tinnitus, facial weakness, and decreased corneal reflex. And they're asking what this is and where it's located. This would be a this would be a vestibular schwannoma, and it's located between the cerebellum and the lateral pons. Okay, so somebody with a vestibular schwannoma would have unilateral hearing loss, tinnitus, and facial weakness, and decreased corneal reflex. And the this schwannoma would be located between the cerebellum and the lateral pons. This is known as a cerebellopontine angle tumor. Okay, like I feel like every time I read, oops, neuroanatomy, it's like a different language. Like every time. Okay, so where is it? Neuroanatomy. Here it is. So neuroanatomy, vestibulocochlear. This is the cranial nerve. Cranial nerve 8. Exit point is auditory canal. Can give rise to acoustic schwannomas. Okay. And here we have, let's see, a 16-year-old male developed cataracts at a young age and 6 months history of left-sided tinnitus and hearing loss. If his diagnosis is the same as that seen in the following gross specimen, where is the most likely underlying genetic condition? Oh my goodness. So Uworld is something very similar to this. They literally mentioned somebody with um, unilateral hearing loss, tinnitus, facial weakness, and decreased corneal reflex. And they asked, what is the location? So in Uworld, they actually asked what the location was. The answer is cerebellum. It's between the cerebellum. The schwannoma is between the cerebellum and the lateral pons, which would be right here. So wherever this pink angle is pointing, right? I'm telling you, I feel like neurosurgeons get paid less. I feel like they get paid less for what they do. I think they should have like $5 million a year. I'm so serious. I cannot imagine neurosurgeons getting paid 900K to 1 million to 1.2 million. It's so hard. It looks It looks the same. They all look the same to me, like the brain. I'm talking about anatomy and specifically. Diagnosis is acoustic schwannoma occurring at the cerebellopontine junction in a young patient. NF2 is likely etiology and can progress to be bilateral if elderly patient, usually sporadic and unilateral. Okay, that's it for that. Next, we have medium sulcus separates anterior two-thirds from the posterior one-third of the tongue, and ulcer distal to the foramen cecum of the tongue will be located on anterior two-thirds of the tongue. Pain from this ulcer will be carried by a mandibular branch of trigeminal nerve. Chorda tympani is a branch of facial nerve, only carries taste in anterior two-thirds of the tongue. So they're saying the median sulcus is what separates the anterior 2/3 of the tongue from the posterior 1/3 of the tongue, and also distal to the foramen cecum of the tongue will be located on anterior 2/3 of the tongue. Pain from this also will be carried by the mandibular branch of the trigeminal nerve. Chorda tympani branch of facial nerve only carries taste in the anterior 2/3 of the tongue. So on the anterior 2/3 of the tongue, pain from that area, the anterior 2/3 of the tongue, will be carried by a mandibular branch of the trigeminal nerve. Okay. And the chorda tympani branch of facial nerve carries taste in anterior 2/3 of the tongue. Okay. So think of it this way: the foramen cecum is a landmark at the back of the tongue. Proximal means to where the origin, means the back of the tongue. Distal is away from the origin, it means to where the tip of the tongue. So if it says distal to the foramen cecum, they're talking about the anterior part of the tongue, which is like near the tip of the tongue. They're talking about proximal to the foramen cecum, they're talking about the posterior, which is back of the tongue. So what carries taste from the anterior 2/3 of the tongue? It's facial nerve, specifically chorda tympani branch of the facial nerve. What carries pain from the anterior 2/3 of the tongue? It is um, trigeminal nerve, specifically mandibular branch of the trigeminal nerve. Okay, next. Okay, they asked to locate on the brain the chemoreceptor trigger zone, which is area postrema on the brain. Okay, let me see if Melman has something about that. Oops. Okay, there it is. Um, a 7-year-old male has ingested substance under the kitchen since what? 7-year-old male, and he ingested substance under the kitchen since, and now he's vomiting. What part of the brain is most likely responsible for the vomiting? Where is it located? Answer is area postrema, which is a chemotactic trigger zone for emesis. It is located on the dorsal aspect of the medulla at the caudal fourth ventricle. Okay, it's right here. So that's where the area postrema is. It is located on the dorsal aspect of the medulla. Dorsal means on the backside. On the backside of the medulla, at the caudal fourth ventricle. Caudal means like near the backside, posterior. So near the okay, area postrema is located at the back side of the medulla and near the posterior fourth ventricle. Okay. So chemo receptor trigger zone, which is in the area postrema of the dorsal medulla near the fourth ventricle. You just have to know the location, okay? And that's where it is. If you see um, like the brain stem, it's there. See, you see this right here? That's the area postrema. Different angle. Let me see. Area postrema would be like here somewhere. So area for streamers here. Okay. Like I said, it literally looks the same to me. So this is the area postrema they're pointing to. The fourth ventricle, the backside of that, right here, right here, and right here. So the area postrema is a part of the medulla oblongata and sits on the floor of the fourth ventricle, which is why it can sense toxins in the blood and trigger vomiting. Next. Broca's is very slow speech, but we can understand the patient. And patient can understand spoken language and follow commands. Patients have weakness in the right arm and leg. So they're asking what Broca's aphasia is. Okay. Um, Broca's is a very slow speech, and we can understand the patient. They speak very slowly, but we're able, like the doctor is able to understand the patient, and the patient can understand when other people speak, and they can follow commands. They can't repeat after someone else though. Like their comprehension is preserved, but like their speech is hard to understand and non-fluent. They have right hemiparesis, so they have weakness in the right side of their body. Wernicke's is fluent and they speak a lot, but they lack meaning. It's like word salad. Think of Wernicke's as word salad. They say a bunch of things, it doesn't make sense. They cannot understand what other people are saying either. They can't repeat after somebody. Um, the associated features for Wernicke's is a right superior visual field defect. Right superior visual field defect. So they have issues with the right side of their right eye on the superior aspect of the right side of their eye. Conduction aphasia is when they're fluent with phonemic errors. Comprehension is kind of preserved. Repetition is very poor. Associated features none. Okay, conduction aphasia. So conduction aphasia is caused by damage to the arcuate vesicles leading to intact comprehension and fluent speech but impaired repetition. Okay. So conduction aphasia is caused by damage to the arcuate vesicles leading to intact comprehension so conduction aphasia is caused by damage to the arcuate vesicles leading to intact comprehension and fluent speech but impaired repetition. So conduction aphasia is when you're fluent but you have phonemic errors, which means like you might say table but you might say Babel, or you're trying to say run, you might say bun. So people can understand you, but you'll have words mixed up in the middle. Um, you can the patient with conduction aphasia, the it's preserved, like the comprehension is preserved. You cannot repeat though. Okay. So here it says 54-year-old female has a decreased fluency of spontaneous speech after a cerebral infarction, and comprehension is normal. An exam shows weakness of lower two-thirds of right side of face. Diagnosis is uh, Broca's aphasia, and the vessel that stroked out was left middle cerebral artery. Okay, so they have decreased fluency of speech, right? We talked about that. Comprehension is normal. Exam shows weakness of lower two-thirds of right side of face. This is Broca's. Okay, so Broca's has decreased fluency of speech, but they can understand everything fine. Like they'll speak like this: 54 decreased fluency of spontaneous speech, or even slower than that. But you can understand if you listen. Next. Okay, so this they're asking to locate this. Okay, so 91-year-old male with history of AFib and new onset difficulty articulating speech. Words come out telegraphic. Repetition is impaired. Comprehension is intact. Where on the following diagram is affected? Also describe the lesions. I think this patient has. What does telegraphic mean? Okay, telegraphic speeches is a speech that contains only key content words like nouns and verbs, like missing grammar words like saying want water instead of I want some water. Okay, so Broca's aphasia. Hello? Yes? ഞാൻ ചോറ് കഴിച്ചു ഒരു 5 മണിയായപ്പോൾ ഞാൻ അതിനകത്ത് ഇരുന്ന ചോറ് കഴിച്ചു ഞാൻ വരുവാ Okay. Finger agnosia is an ability to recognize, name, or distinguish one's own fingers, classically seen in Gertzmann syndrome. Well, so Gertzmann syndrome, you have finger agnosia is an inability to recognize, name, or distinguish one's own fingers. It's in the parietal lobe. Acalculia is an inability to perform simple mathematical calculations, classically due to parietal lobe lesion. Yep. Okay. So that's that. Choice E. Supramarginal gyrus. No idea. Role in empathy, interpreting people's gestures. Oh gosh. I think I know a few people that have this issue actually. Interesting. Okay. E is up there. Yellow. Okay, next. Choice F. Okay. Arcuate fasciculus. This is conduction aphasia. Impaired repetition only. Well. Yeah, that one you can't that patient cannot repeat. They also say Babel instead of table, but their fluent is fine. Like the fluency is fine, and their comprehension is fine also. And that's conduction aphasia would be choice F. Let's go back and look at it. Choice F is up there. Okay, so what we really need to know is A, C, and F. A is Broca's, C is Wernicke's, F is conduction aphasia. If a stroke sounds like Broca but repetition is not impaired, what is that? Transcortical motor aphasia. Repetition is not impaired. Okay. Repetition is not impaired. Yeah, because the Broca's repetition is impaired. If the repetition is not impaired, that'll be transcortical motor aphasia. If a stroke sounds like Wernicke's, but repetition is not impaired, if a stroke sounds like Wernicke's, but repetition is not impaired, the answer is transcortical sensory aphasia. Okay, Wernicke's repetition is impaired. Oh my gosh, repetition is impaired in all of them. So Broca's, Wernicke's, and conduction, it's all impaired. So if stroke sounds like Wernicke's, but repetition is not impaired, the answer is transcortical sensory aphasia. If stroke sounds like both Broca and Wernicke at the same time, but repetition is not impaired, the answer is mixed transcortical aphasia. If stroke sounds like both Broca and Wernicke's at the same time, and repetition is impaired, the answer is global aphasia. Stroke sounds like Broca and Wernicke's at the same time, repetition is impaired. Oh, that means they can't repeat, like they can't repeat what you said. They also can't speak fluently. They can't understand. Global aphasia. So if someone's saying word salad and other times they're speaking very slowly, they can't understand you and they can't repeat what you said, that's global aphasia. Broca's aphasia, which vessel is affected? Answers left CA, left MCA, left middle cerebral artery. Now, 72, Wernicke's aphasia, which vessel is affected? Left MCA, which is the same. 72, male, Broca's aphasia, where in the brain is affected? Answer is inferior frontal gyrus of frontal lobe. Okay, so 72, male, Broca's aphasia, where in the brain is affected? Answer is inferior frontal gyrus of frontal lobe. So, inferior frontal gyrus of frontal lobe. Okay, right here. Okay. The 72, male, Wernicke's aphasia, where in the brain is affected? Answer superior temporal gyrus of temporal lobe. Superior temporal gyrus of temporal lobe. Okay, I'm gonna highlight this. I'm gonna highlight that and save it, so then I can go back and look at it. Okay. So 72 males Wernicke's aphasia, where the brain is affected, is the temporal lobe, and this will be superior temporal gyrus of temporal lobe. Okay. Remember area C? It's over there. Right here. This is the front of the brain. This is the back of the brain, frontal lobe, and then this is the temporal lobe. Okay. 72 can't draw clock face properly. Answer. Diagnosis and what's the answer? Answer is hemi-neglect syndrome caused by stroke in non-dominant parietal lobe. Right MCA in most people leads to neglect of left visual field, although the patient can still see perfectly fine. Hemi-neglect usually affects left visual field because most brains are left, not right dominant. Hemi-neglect in the right field is rare because of redundant processing. Identify. Oh my gosh. Okay, I'm gonna try this. Yo. Let's see. A would be frontal lobe. It was Broca's. B is premotor cortex. C is primary motor cortex. D is primary sensory cortex. Oh my gosh. E is primary auditory cortex. Where's the E? Oh. F is Wernicke's area. G is occipital lobe. Let's go. Okay. A, frontal lobe. B, premotor cortex. C, primary motor cortex. Okay, A is frontal lobe, yeah. B is medial premotor cortex. B is premotor cortex. So if somebody's planning on making movement of his left leg, he's using area B of his head, which would be medial premotor cortex. C is medial primary cortex, which is if which is the answer if post-stroke patient has weakness of left leg. Medial primary motor cortex. Okay. Medial. D is medial primary sensory cortex. The answer if post-stroke patient has sensory disturbance of the leg, like numbness of the leg. E corpus callosum. F thalamus. E corpus callosum. E corpus callosum. Okay. And F is thalamus. G is midbrain. F is thalamus. G is midbrain. H is pons. I is medulla. J is cerebrovermis. The answer: the patient has truncal ataxia. K, posterior lobe cerebellum. The answer: the patient has right limb ataxia. Gosh, I hate this so much. Like, I hate it. I hate it so much. Okay, that's me venting. Leave me. Okay. LMNOPQRSTUV. You can read while I try to memorize this. I just don't understand how anyone would be interested in this. This is my arch nemesis. So, frontal lobe. If somebody has frontotemporal dementia, that'll be in the frontal lobe. Okay. Okay, let's try this. 69-year-old female with history of hypertension and stroke, tongue deviated to left side. Which of the following letters corresponds to stroke lesion? Somebody's tongue deviated to the left side. They have a hypoglossal nerve lesion. Which of the following letters correspond to the stroke lesion? Okay. So somebody's tongue goes to the left side, right, left. Okay, left. Um, what the heck? Okay, I'm gonna pick B. I don't know. Answer is A. Okay, good. The fuck am I looking at? I don't know. Yeah, I get that, but stick with me here. Answer is A. Medial medullary syndrome. That means for step one, literally these type of cross sections. You don't need to worry. You don't need to. You don't need to know every structure labeled on the cross section. Waste of your time. And headspace. Yes, you merely need to know that ipsilateral tongue deviation equals medial medullary syndrome. So, if the tongue deviation is to the left, you say, oh, well, that must be medial medullary. Check. Medial medulla on the same side. Well, just choose the letter on the left side of the cross section. That is that is most medial. This is applied by the paramedian, oh my gosh, branch of the anterior spinal artery. Okay. If tongue deviates to the left side, the answer is medial medulla of left side. So, um, this patient trying to do this 74 male with unilateral resting tremor and shuffling gait, where on the MRI represents the location as pathology. This patient has Parkinson's disease, I think. Yeah. So, it's not A. I don't think it's B. It's not F. It's either D, C, or E, I think. Hmm. I don't know. I know D. Let's see. Oh, yay! It is D. Maybe what it is, if your brain like looks at stares at something long enough, maybe it will pick for you. Because I know dang well I don't know what the heck that I didn't know what I was looking at. I don't even know what D is. D is a midbrain. Okay, substantia nigra pars compacta are located bilaterally within midbrain. Okay. Okay. Yeah, I was looking at the choice A. Isn't that your eyeball? So no. And then B is medial optical gyrus. C is parietal lobe. Okay, D is midbrain, which is where the substantia nigra pars compacta is. E is the cerebellar vermis. F is occipital lobe. I feel like I'm doing rocket science here. Okay, 32 and hiking Connecticut. Circular rash on forearm. Bell's palsy. Which nerve of the following diagram explains findings? Um. Okay. Yeah, this person has Lyme disease. Like, I love stuff like this. Like, I love microbiology. I love immunology. I love psych. Like, those are my areas. I love it so much. I'm like, I might have an obsession with them. Okay? It's like, for example, we know this is Lyme disease. But if you ask me, what the heck? What is it? Which nerve on the following diagram explains the findings? They're asking for facial nerve. They're asking, yeah, so where does it come out of? I mean, where does facial nerve come out of? Gosh. Well, and where does facial nerve come out of? Is it the diencephalon? Is it the midbrain? Is it the pons? Is it the medulla? I'm gonna pick and say the pons, but I don't really know. Hold on. I think I remember facial nerve and something with superior orbital fissure. Oh, okay, I'm gonna guess, and I'm gonna say um, EFGH. I'm gonna say H. I have no idea. Are you serious? I'm telling you, my brain is doing stuff. Oh my gosh, I'm excited. Okay, look, answer affiliation of choice: H. Bell's palsy, secondary Lyme disease. Oh my gosh. Maybe reviewing questions does help, like a lot more than you think. Cause I just been sitting here reviewing everything. I made some 4,000 notes, like 4,000 um, notes on my Uworld, and I'm like, okay, it's a mix of everything I've ever studied, everything I've ever done pertaining to my studies, MBME content, Uworld, random things, random questions I see on YouTube from, uh, you know, doctors that teach. Wow, and I feel happy. I feel so happy. Okay, taking a break.